welcome to this first episode of OncLive GI Talk, a review of data from the ASCO 2020 virtual meeting. I'm your host, Dr. Yelena Janjigian from Memorial Sloan Kettering Cancer Center in New York City. Joining me today in this discussion are my colleagues, all experts in the field of GI oncology. Dr. Jaffer Ajani is from MD Anderson Cancer Center in Houston. Welcome, Jaffer. Dr. Daniel Catenacci is from the University of Chicago. And Dr. Zev Weinberg is from UCLA Medical Center. Welcome, everyone. Today, we're going to talk about GI malignancies, including the results of key data sets presented at ASCO 2020 virtual meeting. We'll talk about the impact of this data had on clinical decision-making and treatment selection for our patients. And hopefully we'll have a lively discussion. So let's get started on our first topic. Section 1 is colorectal cancer. We'll start on the other side of the GI tract. We're all excited to see the plenary session this year to be GI, it was wonderful to see a biomarker selected study, phase 3 Keynote 177 study, looking at MSI-high mismatch repair deficient metastatic colorectal cancer. And perhaps, Dan, you can start the discussion. What are your thoughts? How does this data change your practice?
So this is a pivotal study. I think it was, an expected outcome to some degree, in the sense that we had seen such benefit in later lines of therapy with MSI-high tumors and immunotherapy, and sort of just a matter of time before we could sort of solidify this in earlier lines of therapy. So this study, this being a randomized phase 3 prospective study with 150 patients in each arm, just showing a clear benefit in patients getting the immunotherapy pembrolizumab versus chemotherapy. That said, there is a drop-off early on. And so my thoughts are here is similar to many other studies that we're seeing with monotherapy checkpoint blockade, and I'm sure we'll get into this when we talk about the upper GI gastric cancer studies, the so-called yin-yang effect, where there's actually worse effect in some patients before then you see a crossing of the curve. In this study, we didn't see that to that degree, but there is a drop there in terms of PFS in patients. That said, the benefit, I think, is overwhelming with a higher response rate, higher progression-free survival, and of course, we didn't see the overall survival data yet. So for me, I think it is practice changing. I will use this in my patients. However, there may be some patients that I might be a little bit hesitant to before I just jump in with monotherapy checkpoint. Those patients could be those that have heavier burden of disease, more symptomatic, poor performance status. You see in the forest plot that there's actually the RAS mutants tend to not do as well. So there are some signs there, and of course there's more work to do to predict who won't benefit from checkpoint monotherapy, whether it's TMB level or PD-L1 status expression or some other biomarker in addition to all those other clinical factors. So, in my patient, I'll have somebody who's sort of a low burden of disease, good performance status. I think I wouldn't hesitate to start with this.
Jaffer, with FDA approval of pembrolizumab in first-line setting for MSI-high colorectal cancer, how do you decide which patients you would offer pembrolizumab? Do you have a clinical suspicion of, who are the 29% who will be the hyperprogressors? Do you test routinely, and is MSI available as soon as the patient comes into your clinic?
So yes, we do check on everyone with metastatic disease, and in addition to HER2. So now we are starting to do it when we order HER2 in untreated setting. And I just started one patient on pembro as first line, and she's already responding after one dose. So the other, what Dan said is very important, because as you know, hypermutated colon cancer, as opposed to other MSI-high tumors, have a lot of alterations, hundreds and hundreds of them, but only 5% are immunogenic. So it's good to have a lot of alterations because you'll end up with few immunogenic, but if you have lower number of alterations, like in gastric cancer, for example, or pancreas, then you have few immunogenic alterations or neoantigens. And that may be the reason, you see such discrepancy in responses to pembro. So a couple of little things I want to mention is there are two very wonderful studies. One was published in Nature Medicine in April, and this is from the Dutch group where they took patients who were MSI-high, localized disease. So they get the endoscopy and the other workup. They're MSI-high and MSI stable, MSS. And then they gave Nivo and Ipi. Some patients just got Nivo. And they took them to surgery. So MSI-high patients, majority of them had complete pathologic response. It's very dramatic. It's worth looking at that study. And then it turned out that some MSS patients also had a dramatic response. So that's one study. And they've done a lot of translational work. So we can learn a lot from that. The other study was published in JNCI same month. And there is a small number of patients, about 11 patients or so, colorectal patients, metastatic. And so they had like one good example where the large liver metastases got smaller. But if you look at the CT scan, you will be sure that there is cancer there. And they took some of those patients to surgery. They had a complete pathologic response. So I think this is going to change the way we view how we will deal with these patients. And I know you have a study where you're looking at liquid biopsy after primary therapy, and then you are going to treat with pembro. So I think, these are going to develop new paradigms for us.
So, Nature Medicine and JNCI, I mean, these are exciting opportunities for clinical and translational research. But Zev, what do you say to your patient when they come into clinic and they don't have, you don't know their MSI status yet, they just, have initial diagnosis. Do you delay therapy or do you just start chemo and then, do quick MSI testing? What do you do?
So I think in colorectal cancer, nowadays we are getting that data pretty fast. Mismatch repair can be done with IHC. I think if you really look at the majority of patients, you're able to get the MMR IHC data back pretty fast. It's very rare where you don't have that data along with a adenocarcinoma already on the pathology report. So I think this is practice changing in all respects. I think that if I had a patient with newly diagnosed MSI-high colon cancer, I would treat them with pembrolizumab right away. I think one of the rare cases where the FDA approval followed so quickly after the primary data being presented. I think if you can think of scenarios where you may not be so comfortable with that, and certainly if you don't have the data, it's not unreasonable to give a dose of chemo, but I would pivot to pembro quickly thereafter for many reasons. I guess the question is going to be, from an overall survival perspective, because everybody uses checkpoint inhibitors now in second and third line, where almost everybody by that point knows if they're MSI high. I don't know if the study will be able to show an overall survival advantage, but time will tell.
Yeah, too much crossover, I agree. Well, since you're in the hot seat, why don't you tell us how you approach, what do you think about the Beacon study updates, doublet versus triplet? Are you considering this in earlier lines of therapy as phase 2 data now is being generated? How do you approach BRAF?
I think in the Beacon study, I mean, we saw the New England publication and we saw the survival improvement of the doublet over control arms. And when you look at the triplets, you are obviously, some elements of clinical impact are affected, perhaps a higher rate of response and perhaps some other elements. But the FDA hasn't approved, as you know, the triplet. It's only approved binimetinib and cetuximab in combination. So I think that's certainly, that's what I would do for now. And I don't see, there are probably scenarios you could imagine where you would want a MEK inhibitor on board, particularly patients who might progress sooner, and see what happens with the addition of a MEK inhibitor. But I think for now the approval has been imatinib and cetuximab. Moving it to frontline will be interesting because frontline BRAF mutant patients are often treated with triplet combination chemotherapy. So it does have actually a high response rate, frontline chemotherapy in BRAF mutated. FOLFOXIRI, bevacizumab has been the standard of care in frontline BRAF mutant colon cancer for a number of years. So competing against that will be a challenge, I think. But I think it's the next step where this is going, certainly.
Dan, what do you think? Have you ever used the triplet outside of a trial?
No, you know, I was a little underwhelmed even from the initial report, and then on the updated information here and overall survival, the doublet therapy really, it was improving very on par with the triplet in my opinion. And so it doesn't really justify the added toxicity for all comers. Now, I agree with Zev though, you know, if there are patients, again, those higher risk people that you think have higher risk features that might be more likely to progress rapidly, high burden of disease, et cetera, you're literally looking for a response, you might do that. But as Zev also noted, it's not approved, the triplet, it's the doublet that's approved. I would also echo the moving it earlier now to first line compared to sort of what an appropriate control arm should be, which is triplet therapy for triplet chemotherapy, FOLFOXIRI with BAV, which has sort of been our practice for some time because we all know that these BRAF mutant tumors do worse. They have a worse prognosis. And so you generally have sort of one shot at it, and their median survivals are on the order of 12 to sort of 15 months. And in patients who could otherwise tolerate triplet therapy, that's my preferred first line regimen. So, you know, I'd like to see data, you mentioned earlier, data like Anchor and others that are being done that, you know, we'd like to have randomized data with an appropriate control arm to really see what the benefit would be there.
Great. So, Jaffer, you mentioned HER2 as a biomarker and routine testing for HER2 in colon cancer. What do you see TDXD data, and how does it fit into the already NCCN listed compendium, you know, options for colorectal cancer and HER2 space? How do you sequence these treatments?
So I think, you know, HER2 is becoming a very important target in multiple tumor types. So breast started it, but now there are a number of them, including lung. So NCCN recommends HER2 testing in colon cancer now. And I think eventually they will, you know, add more. But this particular molecule, as you well know, is a trastuzumab with a conjugation with camptothecin type of molecule. But there are multiple of them. And so more than TDM1. TDM1, I think, has about 4 molecules. This one has 8. So that comes with a little bit of a price also. And the difference between breast and gastric, this debate has been going on for some time, don't have enough data in colorectal, is about the pharmacokinetics. You know, so the dose used in breast cancer is less than studied in colon cancer and gastric cancer. So this is 6.4 compared to 5.4, which is a step down. So I think it probably comes with a little more toxicity, but there's no question that this particular molecule in this study produced a response rate of about 40%, durable responses, and the expected side effects that we saw in the gastric study. So I think this is a single arm study, but this probably may get approval based on high activity. I'm not sure, but this will be.
Would you use it over tucatinib, or, you know, what, or traz plus, you know, pertuzumab? Do you think?
Sure. Trastuzumab, we already have some data in colon cancer. Certainly this one is overall better, but then again, patient selection is going to become very important because of the toxicity profile of this drug. So I think this target is here to stay. I mean, in colon, it's going to become important.
And what do you think the sequencing platforms and the assessment going to be fast enough to get this data in first-line setting in colorectal, or are we going to need to rely on IHC and FISH? Because in colon cancer, remember, RAS is so much more of an issue, and you need to know the RAS status of the tumor before you give them anti-HER2 therapy. So how do you approach a patient in first-line setting with potential delays in getting tissue and sequencing done in real time?
Yeah,
Go ahead.
Yeah.
I thought you said Dan. Sorry, Jaffer, but I think this is sort of a plug for ctDNA analysis, where the turnaround time is like literally 7 days from the time of the blood draw, and you can get the result back before you place a port. And so you'll know the RAS status and the HER2 status all pretty much simultaneously, and MSI-high for that matter, in some of the ctDNA platforms out there. So for me, that has always been the reasoning and the draw towards ctDNA, and this study is yet another example now that it just makes it much more practical in a newly diagnosed patient, but even at a time if you haven't tested it before, at the time of progression, where if you have to set up a biopsy and or try and get an archived sample and get the result, it's just faster to do the blood draw. So I think that's one way to address that issue. My thoughts just in general about this study, I agree with a lot with what Jaffer said about the molecule itself. 5% of this disease is HER2 amplified. And this is becoming a very crowded space very quickly with a lot of different approaches. You mentioned trastuzumab and tucatinib, pertuzumab and trastuzumab, TDM1, and now this agent. And so, at this point, there's only sort of phase 2 smaller studies, 30 to 50 patients, and their response rates are all very similar in that range. And so I think this target's here to stay. I would agree. I think at this point, the next phase is to determine which of the ones we should use and in which order. Right now, all of these studies have been in the sort of later line after failing platinum, irinotecan, pretty much bevacizumab. And as you mentioned, they're RAS/RAF wild type. So can we move these earlier? Should we? These are the next phase of studies. And my concern with this molecule is the sort of the toxicity rate that comes with it, namely the pneumonitis, which is about 6 to 10% of cases, some of which are fatal. And so when you have other anti-HER2 agents that are potentially equally as effective, I'm sure trastuzumab monotherapy is not good, but trastuzumab plus chemo or irinotecan, which would be the fair comparison to this agent, I would say. I think ultimately, I want to see that data before I expose my patient to this at an earlier line that compared to some of these other HER2 therapies that are available that do not cause those toxicities.
Jaffer, did you want to comment?
Yeah, so I think I agree with Dan that, first of all, whether to move in the first line is not, I think it's pretty obvious that we have to target HER2 along with, non-HER2 component of the cancer. So colon cancer, I think it's easier to combine trastuzumab and maybe tucatinib and a few other agents that target HER2 with chemotherapy. But this particular molecule, I think at this dose will be difficult to combine with, say, for example, FOLFOX or other combinations. So this is something that we have to continue to debate, I think.